All right, what's going on, everyone? Welcome back to the second installment here. So what we're going to be going over today is going to be soft tissue trauma, um, burns. Burns is going to be a really important one, and then we are also, if we can fit it into schedule, we're going to be doing Chapter 6, head, neck, and spinal trauma. Um, so let's get into it. So let's see here. There's a lot of stuff we can skip here. Here's going to be some of our DCAP BTLS that we're going to follow. It's going to be really important with any of our traumas that we're going to be following that. Risk factors for any soft tissue trauma is going to be our age. The older or younger you are, you're going to have a less pliability. Oh, um, there we go. You have less pliability of that skin. It's going to be maybe be easier to stretch out or tear. We do have some of our prescription medications, E2H, and occupation, I guess. For the most part, just understand that we have layers of our skin. So we have our epidermis. Epi is going to be on our top. For our prefix, it's going to be this small little layer right here, right under the epidermis. We're going to have our sensory receptors. This is going to be really big in cases of burns. When we look at first and second degree burns, these are going to have a very high pain index just because these receptors are being affected. But when we go down into full subcutaneous burns or our third degrees, we actually singe off all these sensory receptors, and you will not have any more impulses. So they may even appear painless. So epidermis, right below that we have our dermis. To follow back up on here, there's going to be a lot of shedding and dead cells that come from this epidermis, where they'll just lay on top of the skin. In the dermis, you're going to have a lot of your vasculature that actually degranulate all that dead tissue or dead skin cells up to the top here. And then we have our subcutaneous. This is where going to be our adipose tissue, fat, and just muscle that's going to lie right under it, as well as you have innervations of your nerves, veins, and arteries that lay really low down into the skin. I have a bunch of glands that really don't matter. Here's our subcutaneous tissue again. Fatty or adipose tissue is going to be in there. This is going to absorb our forces of trauma and protects the tissues and vital organs. Sub-Q, very important. We have our blood vessels that are actually going to innervate within our skin. We have our lymphatic system. You can almost treat this as a filtration system that acts in the body before it actually goes back into circulation through the heart. So you have your artery here, and then it'll kind of just branch off into a lymphatic vessel, and it'll just take out any pathogens or byproducts out of the circulatory system and remove them properly. We have our muscles. Those are pretty cool. Tendon lines, don't worry about those. So we have our closed wounds. Most commonly you're going to see on blunt force trauma is our contusions right here. So this is going to be actually just blood pooling under the site of blunt trauma. Also can be referred as ecchymosis. So when you do actually have a blunt injury to, let's say, you damage your shoulder, somebody hits it, you're going to have an inflammatory response, and our first sign that we're going to see is arrhythmia, which is just reddening of the skin. And as those blood vessels actually break, they are going to send all that fluid, blood, into interstitial space out of our circulatory system. We're going to lose stuff like O2, which are carrying components of that, and as it loses O2, it'll become dark and more blue in appearance. So as you can see here, there's actually a little blue outline, and we still have pretty O2-rich blood, our ecchymosis appearance. We have our hematomas. It's just a collection of blood beneath the skin. Contusion, hematoma, pretty interchangeable. Just know in our thighs, legs, and arms, there may be enough fluid loss that we actually do see signs and symptoms of hypovolemia. Like we talked before, I think it was in chapter 2, we have our crush injury. Crush syndrome, excuse me. This is going to be in cases of, let's say we have a industrial call we get called out to, and some guys piled in between boxes. He's against a wall and he gets squished by a box. With that decrease in perfusion in an affected limb, we're going to see things of myoglobin, potassium, lactate acid, and some other toxins that are going to build up just due to that anaerobic respiration. This is going to cause severe metabolic acidosis. These are going to be really crucial to the kidneys and hearts. Over here we have our open wounds. We have our abrasion. We all know what an abrasion looks like. Epidermis and dermis are going to be involved in these. They're going to be very superficial. They're going to kind of ooze, stuff like that. Only thing we're really going to be able to do is if there's any glass, dirt, stuff like that, we'll irrigate it out with sterile water. And then we'll just do infection control, because this is still an open wound, and pathogens can still get in here and find their way into your circulatory system. Lacerations is just going to be a jagged cut. Same thing. Infection control. Incisions is going to be more of a surgical or a more precision cut. We have our punctures. If we do have stuff that's penetrating as a puncture, we're just going to stabilize it, and infection control for the most part. Or impaled objects, that's what I meant, excuse me. Avulsion is going to be tearing away or separation of a body tissue. It can be partial or complete. Stuff we all know, vascular phase. If you want, go ahead and pause this and read over it. I'm just going to skip right through it. We have our inflammation process. So this is going to be complex processes of local cellular and biological changes in consequence of injury or infection. Early stage of healing. So you'll have white blood cells, proteins, and hormone-like chemicals that are going to be released to promote that process. I think for the most part we can skip a lot of this stuff. It's just really not going to be helpful at all for our test. But feel free, all my notes are on Google Drive if you need to go back on this. Here's all of our risk factors that will increase the chance or exacerbate an infection. Of course, HIV and AIDS are going to be on there. Gangrene is going to be a deep space infection, just caused by an anaerobic bacterium, Clostridium perfringens. Yeah. I'm sure we've all seen gangrene. Treatment for this is going to be antibiotics, surgery, or a hyperbaric O2 chamber, just so you can get as much oxygen in there as possible and you can drive out that bacterium. Tetanus is going to be caused by the bacterium Clostridium tetani. It's going to be referred as lockjaw. It's just going to be a bacterial infection of your central nervous system. The assessment finding here of actual lockjaw is going to be called mandibular trismus, jaw clenching. Yeah, there you go. Diphtheria vaccine, tetanus. I know this one's diphtheria, tetanus, and something else. Just get that vaccine, you'll be good. Some things that can impair our clotting factors are aspirin, Plavix, warfarin, heparin, any of our anticoagulants or platelet inhibitors. We have our compartment syndrome that we talked about, I believe, I want to say in chapter 3. So we have these, we have our tibia and our fibia, and we have different compartments within a leg. If these do get hit with blunt force trauma and, we start an inflammation process, we're releasing histamine, we're having an interstitial fluid shift. These will actually compress against these arteries and veins and cause a decrease in perfusion. What they might have to do in a hospital setting is actually take a scalpel and cut it into the leg and do a fasciotomy. These little compartments are actually referred to as fascia, and excuse me, the fascia is what encloses the compartment. So they'll come in and actually do a little incision. Crush injuries here. We got our syndrome here. So when body parts are trapped for more than 4 hours, we're going to have signs of necrosis and increased metabolic byproducts. So we're going to see things like myoglobin, potassium, lactic acid, phosphate. And this will actually, with these byproducts, they will cause rhabdomyolysis, which is going to be an acute pathological process that involves destruction of skeletal muscle. Very bad, no bueno. So if you ever have a trauma patient here, we'll look for DCAB BTLS. This will kind of help you form any assessment findings. If you do forget, just run through this and you should be good. Also remember your trauma assessment here. We have our beta-cytosine safety. Everything stays the same. IRC, AVPO, any injuries to the airway, CBPS, check all those. And then just right here on 19, we have our shock management. Really, any trauma patient that you deem as critical or maybe priority 2, high flow O2, keep them warm, and rapid transport or position of comfort. Just because of that possibility of exsanguination, that blood is carrying O2, so you're going to have a decrease in capacity to carry it. You're losing, water out of your bathtub, and just keep them warm, just so you can promote that clotting. The colder a patient is, the slower those molecules move, and the warmer you can keep them, the better. We have, of course, our focus history and physical exam, and then our head to toe. Hemorrhage control, direct pressure is going to be our first line here, and then we're going to go to a tourniquet as the last option you're going to want to do. If we have something, let's say maybe right in our bicep, you're going to go nice high and tight, just kind of just below the shoulder blade. Just find a decent area. If we have somebody who just has a sprain or whatever, you're going to do the rest, ice, compress, and elevate. Some options that we have for any pain management is we have our morphine, 4 milligrams, or our fentanyl. You can do 1 to 2 mics per kilo, and our ketamine, which don't actually look at this. It's going to be 0.2 milligrams per kilo for Macomb County protocol. I still have yet to look at what National Registry would deem it as, but just understand that if we're doing pain management, these are possibilities of what we could go to. With head trauma, be careful with morphine. If we do administer that, we are going to see an increase in ICP. So if need be, fentanyl will also increase ICP, but not as major as morphine. Ketamine, I'd still have to look into, but I don't think it will. We have our anatomic structures. If they are injured, the scalp, of course, will bleed heavily, highly vascular, no vasospasmatic mechanism. That's just because if we have blood up top here, we don't want any valves, nothing like that. So it allows for gravity to freely flow down back to the heart. Direct pressure, gastric irritant. So blood, just be careful if that's in the airway, your patient might vomit. Of course, be ready to suction. Really, if we have C-spine taken care of, and you do have blood or anything in the oral cavity space, before you even get an airway, you're going to be suctioning. That is something that needs to be corrected as soon as possible. If we have a iridomastoid fracture or whatever damage, if we do have a leaking fluid coming out of the ears, allow that to drain. This will help aid in decreasing that ICP. Neck, direct pressure, occlusive dressing, of course. Yeah. This stuff's all pretty simple. Be careful on your bandaging. Just don't make it too tight. We really shouldn't be reminded on this, but just until blood flow stops, and you'll be good for any bleeding. Impaled objects, we're going to immobilize. Depending on where it's at, we'll check CSM, immobilize, Check CSM again if you need be. So with our crush syndrome, let's say we have somebody pinned up for more than 4 hours, whatever it may be in an industrial facility. Some symptoms they might have is, of course, pain, surprising there, decreased motor function, paresthesia, lack of sensation. So with these byproducts that accumulate with rhabdomyolysis, so this myoglobin is going to accumulate in the renal tubule. You may have exacerbation of renal failure, or when the patient is discharged, they might have to go on dialysis for a little bit just so the kidneys go up to full function. We have our phosphate. Books didn't say too much on that. We have our potassium. Normal values are going to be 3.5 to 5.0. Of course, we know potassium is in charge of the repolarization of the ventricles. And so we'll see things like acute hyperkalemia. We're going to have those peak T waves, and you might be able to see a decrease in your P wave. Things that we're going to do for our crush syndrome is, of course, ABCs. We're going to establish an IV. We're going to run some fluids. And as soon as or just before you're about to extricate them, you're going to hit them with the sodium bicarb. Try to keep them on the EKG monitor if you can, if we have any arrhythmias that happen. You can also consider calcium. So since we are building up in acidity, we'll push the sodium bicarb. And of course, since we have an influx of potassium, we can also combat it with calcium. Yeah. Normal saline, don't worry about the 30 mils per kilo per hour. And a hyperbaric O2 chamber. This is going to drive O2 into poorly oxygenated tissue and destroy anaerobic bacteria. Look at this nice, pretty first degree. Calcium is in charge of contracting the muscle, and potassium pumps the heart and repolarizes. These are the 6 P's of the compartment syndrome that we have here. Poikilothermia is going to just be a limb that is cool to the touch. Here's some more. Facial and neck fractures are not too cool. You do have your airway here, so you'd like to keep that, I'm assuming. Here's the treatment. Should be pretty simple. If we have a thorax injury, very minor stuff like rib bruises may actually be a little bit worse than you think. So it could be possibility of a punctured lung or pulmonary contusion, or cardiac contusion, which is even worse. Some things that we have is colon sign. So if we're looking for internal bleeding, if you remember colon sign, we take a C and we take 2 of them like Chanel, put them together, and it'll create a little circle, and that circle will be our belly button. So colon sign will be our periumbilical ecchymosis, and then we have Turner sign, which is going to be for our thorax or our back, and that'll be that retroperitoneal ecchymosis. We have narrowing pulse pressures as well, which we went over in the last video. To go over it super quick in case you skipped that first one, pulse pressure is just going to be the difference between your systolic and diastolic pressure. So we'll go 120 over 80, and then we'll have a pulse pressure of 40. If we have something like 140 over 128, pulse pressure of 12. So anything to the thorax or the neck, we're going to use an occlusive dressing. Hemopneumo, big signs are going to be muffled lung sounds, tracheal deviation. It's going to be contralateral, so if we have our busted lung right here, we'll have a shift like that within our trachea and flat neck veins. Abdomen, just prevent shock, dress open wound, transport. Just know your thoracic anatomy, where some things might be, if they're going to be like more retro or more anterior in positioning of your perineum, or peritoneum, excuse me. So yeah, that is chapter 4, super nice and easy. Chapter 5 is where it gets a little bit more exciting and interesting. So burns are pretty cool, just because of how much stuff is going on. And I mean, they're pretty easy to take care of. Just know your assessments and know how to treat them properly, and they will be very simple for you. So the skin, as we know, prevents fluid loss and prevents for any pathogenic materials to come into the body itself. We went over the epidermis, dermis, and our subcutaneous. So I believe that we can skip over this. Functions of the skin is going to protect us from infection, gives us sensation, perceiving pretty much everything, temp, touch, pain. Contains bodily fluids, temp regulation, and insulates us from trauma. So it'll actually absorb any of that energy that's given to us. So we have things like thermal burns, which I think will be okay on skipping. Zona coagulation, stasis, and hyperemia. Just know those if you need to. Go ahead and pause this if you need to review over it. So we have phases of the body's response to burns. This can be our first, is our emergent. We're going to have a catecholamine release. So we have our catecholamines of epi, norepi, and dopamine, and pain mediation reaction. So we're going to see things with our catecholamine dump. We're going to see tachycardia, tachypnea, mild hypertension, and mild anxiety, all due to our catecholamines. Then we're going to have a fluid shift. This is going to have our intravascular fluid go into extravascular, and we're going to see things of edema build up. Last up to 24 hours. We're going to have a release of histamine, bradykinin, prostaglandins. Hopefully I said that right. And our capillaries will leak plasma. And then after that, we're going to have our hypermetabolic phase. This is going to be the healing phase, essentially. The body is just going to increase that metabolism to quickly and as efficiently heal a burn. We have things like electrical burns. I'm not too concerned about these so much. Just know that with the electrical, our nervous system can be affected pretty badly. Yeah. We have our chemical burns. Just be careful with the chemical that is involved, that sometimes if you irrigate with water, this may actually exacerbate what's going on. So just understand what you have in front of you before you treat. Bases are going to be a little bit more dangerous. You're going to have that liquefaction necrosis. Acids are going to be pretty bad too. We have our radiation. You can go ahead and skip this. Inhalation is going to be really crucial. So when we do have that superheated air that goes into the respiratory tract, you have things like your cilia gets damaged. You're going to have bronchoconstriction, inflammation, stuff like that. So just be very aggressive with anybody you see signs and symptoms of airway compromise or involvement. If we have charring, if we have singed eyebrows, stuff like that, just be ready to intubate the first thing you get. Cyanide is a toxic inhalation, or at least part of it. Amyl nitrate is going to be your drug of choice for that. We do also have carbon monoxide poisoning. Just know that our hemoglobin affinity is going to be 200 more times than that of oxygen. So instead of oxyhemoglobin, we're going to have that carboxyhemoglobin. Super hard to get rid of. You might have a false reading on your pulse oximetry. So no matter what, give them the highest amount of O2 you can. Just hyperoxygenate them. It will be okay. Just get them over to a hyperbaric chamber, and you'll be solid. Here's this little chart on how we will treat the algorithm here. And yeah. So we have our burn depth here. So superficial, partial thickness, and full thickness. So with this, you're just gonna see that erythema. It's gonna be pretty tame. Still, I mean, a burn regardless is gonna be bad. Just not as crucial. Over here on partial thickness, we're gonna have that erythema. White to red skin, you're going to see blisters. It's going to be extremely painful just because of those nerve fibers or lining. They're just directly in that area. And then this where you have full thickness, it's going to be complete charring, dark brown or white to appearance. Little to no pain. Those nerves are going to be all cinched off and just not working properly. So now we have here our rule of nines. So you can kind of see here everything is going to be equal to 9. Just don't get tripped up here. The entire arm. So this is going to be anterior and posterior. So 9, 9, 9, 9. Genitals, no matter what, are going to be equals to 1 for person, and then you can see as our pediatric 3.5. Give me 1 sec here. Hey, what's up? All right, sorry about that. So we have our nines. So go ahead. And this is one thing that you're going to be wanting to do a mind dump on with your little piece of paper when you go to National Registry. I need a pencil. I need paper. All right. All right. So hypothermia is going to be a super big thing that you're going to want to be able to manage because of that fluid shift. All that fluid's going to come outside. So we're going to have our convection as our source, and then as well the body kind of loses its ability to regulate its temperature. Release plasma, yep, evaporate. Yeah, super simple. So here we have our hypovolemia, typically seen in at least 15 to 20, and then beyond that, going further. Also, you're going to have an electrolyte loss. So put them on the EKG monitor if you can. Of course, if you have stuff like this, don't put a fucking electrode on that. This is actually Eschar. So think of a hot dog when you put it in a microwave. The hot dog is, it's solid, but once you put it in that microwave and you start heating up, it kind of shrinks, and then once it gets so stiff, because you're contracting everything, once it meets at like a pressure point of where it's so high, it'll actually just bust open and rupture, sometimes. But this, you can see they actually did what's called an escharotomy, just to release that pressure, so you can avoid, like with circumferential burns, you do not have things like compartment syndrome. So it's not within the fascia, but it's just because of that fucking raw pressure that's squeezing against the entire muscle and all that tissue. It's going to help release all that. Yeah. Infection, not really cool. Organ failure, kind of whack. Hypovolemia, of course. So some of the two things that are most important in hypovolemia is restoring perfusion to your brain, and then usually your kidney is involved too pretty quickly with losing all that. Special factors, peds and elderly, of course. And here's going to be our assessment here. Ensure a patent airway. We're going to look for any residue of singed facial hairs, our mouth, nose, stuff like that. If we have any charring. Stridor is going to be evidence of an upper airway obstruction, hoarseness, coughing. Be ready to fucking intubate these people. They will crash pretty fast. And right here, Devin, I'm sure, has this tattooed on his arm somewhere. This can be our RSI. So we'll do our succinylcholine, which will be our short acting, and then we'll hit him with the rocuronium right after. 1 mil per kilo, IV or IO, and then same with the rocuronium. Best way I can remember this order is you're going to give someone like a quick suck, and then you're going to rock and roll all night. Best way I can remember it. High flow O2, prepare to intubate, and if we do have CO poisoning, hydrocobalamin or B12A is going to be administered. That's going to be in a hospital setting. Box score, we have, it's just kind of like a mortality kind of percentage. It's nothing really I don't think we will have to know, but it takes factors in the patient's age, body surface area burned, and respiratory involvement. This will add 17, but you take these things, and between 130 to 140, you're most likely going to have a death involved with this patient. So we have a 65-year-old with 27% burns with respiratory involvement, 109. So you're kind of teetering along that high-end score, but you know, if they make it out alive, like that's kind of crazy. Yep. If we have some pretty small stuff, we're just going to be bandaging with dry, sterile dressing. We have our morphine, fentanyl. Yeah. Of course, if we have a burn, remove clothing and jewelry. That increased pressure could almost act as a tourniquet. Here we go. Second and third degree, dry dressing. Just do infection control. Keep them warm. High flow too. Bilateral large bore IVs. Run some fluids. And here we have our Parkland formula. I'm sure we went over this plenty enough times, but 4 ml times your body weight times your body surface area, and then you'll get your full dosage here. Divide that by 2, and then you'll have one that goes into 8 hours and one into 16. And yeah. And then auscultate breath sounds before normal saline administration. If we do have fluid in the lungs, just bring it back a little. That's carotomy, incision. Yeah. CO poisoning, give him CPAP. Cyanide, amyl nitrate, or sodium nitrate. Bunch of chemicals. I don't think they really matter. Go ahead and pause if you need to review that. But yeah, that's going to be it for Chapter 4 and Chapter 5. As always, send me a message if there's anything you want me to go over, or you know, like, comment, subscribe, all that good stuff. So yeah, I think next we are doing, so that was 4 and 5. So we're going to be going over head, neck, spinal, and then chest trauma as well. So I'll see you in the next one.